Welcome to the second in a series of presentations on spinal radiography. The intent of this presentation is to provide a description and give examples of vertebral column anomalies that are most commonly encountered during radiography of dogs and cats. Anomalies are common and include congenital and developmental malformations. In this presentation, we'll talk about some that are oftentimes incidental, the transitional hemi and block vertebrae, and then we'll talk about two that are usually clinically relevant, which are atlantoaxial subluxation and cervical spondylomyelopathy. Let's start with the typically incidental abnormalities. A transitional vertebra has the anatomic characteristics of two different anatomic divisions. So they are going to happen at your junctions, like the cervicothoracic, the thoracolumbar, and the lumbosacral regions. Again, these are typically clinically insignificant. However, if you have a thoracolumbar transitional vertebra, which may not have the right number of ribs, that could cause confusion for surgical approach if you're using the T13 and its ribs as a way to localize your surgery. And lumbosacral transitional vertebra, especially when L7 or the last lumbar vertebra is kind of fusing as part of the sacrum, can have associated intervertebral disc herniations and compression of nerve roots from altered loading that can happen at that level. Here's an example of a cervicothoracic transitional vertebra, and in this region the most common anomaly is the presence of vestigial ribs on C7. This is a lateral view, pretty rotated. T1 has the tall spinous process and the first set of real ribs, but C7 here, actually the transverse processes have elongated and are kind of resembling vestigial ribs. And in fact, in this one, they've actually fused to each other. This is rarely relevant clinically. At the thoracolumbar junction, the most common anomaly is asymmetric development of the 13th rib. So maybe one is developed and the other is not, or both are absent, or you can find ribs present on the first lumbar vertebra. So the lateral and ventrodorsal views here are from the same patient, and if we look at this one that has a transitional vertebra, it's actually of L1. We can see the sacrum, and remember there are 7 lumbar vertebrae, so if I count backwards, 7, 6, 5, 4, 3, 2, 1, this is L1. T13 should have the last set of ribs, but I see additional ribs that are more evident on our ventrodorsal view, so L7, 6, 5, 4, 3, 2, L1. There is a tiny little, what I'll call hypoplastic rib, and then the transverse process on the left is actually kind of really wide and elongated, trying to also form a rib. So L1 here has 2 ribs, but they're asymmetric. The lumbosacral transitional vertebra can be either L7 resembling the sacrum, or it can be the first sacral segment resembling a last lumbar segment. The most common that we'll encounter is what is termed sacralization of L7. This is a ventrodorsal view. We can see that best on the ventrodorsal view, and we can see that here's a normally formed lumbar vertebra with 2 transverse processes. This, if we counted from this patient, is actually the last lumbar vertebra, so L7. On the right side, there is a normal transverse process, but we can see on the left side that the transverse process is actually fusing to the ilium, and so it is fusing like the sacrum would, and that would be why we call it sacralization of L7. And again, when L7 is the one that is sacralizing, we can have that altered load, and it can actually lead to either intervertebral disc herniation, like I said already, but it can also lead to asymmetrical hip conformation. So on the same side as that sacral-like transverse process, the hip may be predisposed to subluxation, malformation, and arthritis. Certain congenital anomalies are very common in what we'll call the screw-tail breeds. So our kind of brachycephalic breeds with small tails like Pug, Boston Terrier, the Bulldog, and in the cat, the Manx breed. These are, again, often incidental, although in some cases the neural tissue can be involved, or adjacent to the anomaly, we can have a problem. And when that happens, we call it adjacent segment disease, which is a broad term that encompasses complications that occur due to biomechanical stresses placed adjacent to the abnormality. We're going to talk a little bit more specifically about the abnormality of the vertebra, but we can also have accompanying spinal conformational abnormalities that some of these can result in. And I have some terms that I wanted to go over so that you'll know those terms and how to apply them. So one conformational abnormality, so we're looking at the entirety of the spinal column, is lordosis. And that is when you're looking at the patient from the lateral aspect and you see that the spine deviates ventrally. So lordosis, like a sway back in this horse. So when the spine deviates ventral from your expected location, that would be lordosis. Kyphosis is, again, from the lateral perspective of the patient, and that is when the spine is noted to deviate dorsally. So this dog back is kind of illustrating that, where we'd expect the spine to be straight, but we have this part where the spine is deviating dorsally, and that is kyphosis. I use a little kind of thing to help me remember. Lordosis, as in low, so low, it deviates ventrally, and kyphosis, kind of rhyming with high, as the spine goes high or deviates dorsally. And then our last conformational abnormality is scoliosis, and this is going to be from the dorsal perspective of the patient because the spine is deviating side to side. So our little dog patient here is demonstrating that scoliosis where the spine will deviate from side to side. So obviously we will identify on radiographs lordosis and kyphosis on a lateral view, and we will identify scoliosis on a ventrodorsal view. So let's talk next about the hemivertebra. The hemivertebra occurs due to failure of development of part of the vertebra, and it's usually in the body. So if part of it does not develop appropriately, you will get an abnormal shape, but that resulting shape will depend upon which part fails to develop. So is it the entire central part? Is it kind of the dorsal part or the ventral part? Commonly, we will identify wedge-shaped vertebrae, and those occur when the ventral part is incomplete. So if we have a normal vertebral body, but then a portion of the ventral part is incomplete, they usually show up like a little triangle with the apex ventrally. So I have an example of a wedge-shaped vertebra here in this patient at T11. This patient also has a very short vertebral body here, very short. It's not really wedged, so this would just be a hemivertebra. That is because the central portion did not develop. Here's an example of a dog that has multiple wedge-shaped vertebrae. The arrows are indicating these vertebrae at T3, T4, T5, T6, and T8. So again, normal rectangle of a vertebral body. And if you see, here's a actually probably more of a hemivertebra because it's not really wedge-shaped at T8. And then all of these others in here are very wedge-shaped vertebrae. It could be difficult or challenging to figure out how many different vertebral bodies are in there, but if we look at the dorsal aspect of the vertebra, we can see a spinous process, another spinous process, the third spinous process, and the fourth spinous process, so it can help us identify which vertebrae are affected. Now, this dog also has the spine deviating dorsally, and that was kyphosis. So these numerous wedge-shaped vertebrae in a row are leading to the spinal conformational abnormality of kyphosis. There is a special type of hemivertebra that we will only identify on the ventrodorsal view. So the wedge-shaped vertebrae we're going to identify in the lateral view, but this butterfly-shaped vertebra we're going to identify on the ventrodorsal view. And this will occur when the mid aspect of the body fails to develop. On the lateral view, it may just look shortened or a little bit abnormally shaped. On the ventrodorsal view, it will be narrowed on midline and then look like it has a pair of wings on either side, and so that's where the term butterfly shaped comes from. This one is at L2. This is a different patient. This is at L6. So again, we can kind of see this butterfly shape of the two sides of the vertebral body on the ventrodorsal view. L7 in this dog is not quite a butterfly shape, but it also is an abnormal shape, and it is shortened, so it is another hemivertebra. A block vertebra is fusion of two or more vertebral bodies, and when they fuse, there can be a variable appearance. They can maybe partially fuse, and you might still see lucency where the intervertebral disc space should be. It may be thinner, or it may actually be completely absent, so we may just see uniform opacity. The block vertebra oftentimes fuses at the body, but you can also have fusion at the lamina and even the spinous processes, so the vertebral arches can be fused. Biomechanically, this block vertebra can act as a fulcrum, leading again to some altered loading immediately adjacent. So the intervertebral disc space cranial to the block vertebra, as well as the intervertebral disc space caudal to the block vertebra. And so that can actually increase the risk of intervertebral disc herniation. And again, that is termed the adjacent segment disease. So here's a lateral view. Probably they are easiest to evaluate on the lateral view of a dog that has a block vertebra of C2 and C3. So we have C1 with our wings, C2 and C3. If you look at these, there is little intervertebral disc space here. I see like maybe a thin, tiny little line there. I also don't see a separation between the lamina and on C2 and C3. And so this is a block vertebra. There's no disc space or articular joint space. Otherwise, the spine looks aligned at the level of C2 and C3. Versus this dog, which I have both the lateral and the ventrodorsal views, this dog has a block vertebra that is comprised of C4, C5, and C6, so three vertebrae. So C1, C2, C3, and then 4, 5, and 6 are abnormally shaped as well as being fused, and then we have a separation and a more normal C7. At this level, on the lateral view, there's also the conformational abnormality of a little bit of kyphosis, and on the ventrodorsal view, this fused or block vertebra is also leading to a little bit of scoliosis. Again, in this patient, there may be more likelihood of intervertebral disc herniation at C3-4 and at C6-7. And then here's an example of a Manx cat that these almost always have some sort of congenital anomaly in the caudal lumbar, sacral, and caudal spine. And this patient has a block vertebra that is comprised of C6, C7, and the sacrum. I can't see any intervertebral disc spaces, and I also don't think I see any articular process joint spaces either, so it looks like it's completely fused. And then the caudal sacrum and the kind of little portion of the tail that's here, so the caudal spine, also look like they're fused as well. So this would be an extensive block vertebra, and there's probably a little bit, it looks like, of kyphosis here with the spine deviating dorsally. So then I want to move into the two kind of oftentimes clinically relevant anomalies, and the first is atlantoaxial or AA subluxation. AA subluxation can occur as a congenital issue, and that's what we're going to talk about now, but it can also be a result of trauma. So, for example, you might have a fracture of the affected bones or trauma to the supporting ligaments that could lead to a traumatic AA subluxation. But we're going to focus on the congenital atlantoaxial subluxation. This predominantly affects miniature and toy breed dogs, and I've listed a few of the breeds that are at higher risk for developing this congenital anomaly. Most of the time, these patients will present when they are quite young, so less than a year, maybe at a year of age. But keep in mind that a patient with a congenital anomaly is always going to have a congenital anomaly, and they sometimes don't present with clinical signs until they are older. However, if you have an older patient that presents with neurologic abnormalities and you identify atlantoaxial subluxation, make sure that that's actually the cause of the neurologic abnormalities and not another lesion. With congenital atlantoaxial subluxation, the dens or the odontoid process of C2 is typically either absent, and the word for that is aplasia, or very small, and the word for that is hypoplasia. Along with that, there are typically deficiencies in the ligaments that support the atlantoaxial joint, so ligaments that are associated with the dens, as well as the ligament between the lamina of C1 and C2. Because of these lesions, there is instability, and ultimately we get cord compression that's going to be caused by abnormal rotation and dorsal displacement of CT into that vertebral canal. There aren't a lot of radiographic findings of atlantoaxial subluxation, but very specific ones that we need to look for. So one, we need to always be assessing in patients that we have a suspicion for this of the odontoid process or the dens of C2. And so again, we know that it's either missing or hypoplastic in almost all of these patients. When there is instability there, we oftentimes identify a widened space between the lamina of C1 and C2, or we see abnormal angulation and or dorsal displacement of C2. Now, I have a clinical tip at the top right of the slide. If we are suspecting we have the right breed, the right presentation, this atlantoaxial subluxation, I like to obtain one additional view. So typically we'll get our neutral lateral, we'll get our ventrodorsal view, but then I also want to get a lateral oblique view. The patient on the left of the slide here is a normal patient, and this actually is one of our lateral oblique views. In a straight lateral view, these wings of C1 will be superimposed over each other, and they're superimposed over our normal dens or the cranial aspect of the body where we'd want to assess for an abnormality of the dens. So in this lateral oblique view, we take and oblique it enough to get those wings separated. And then if you remind yourself, the dens is this kind of finger-like projection coming off the cranial aspect of the body of C2. So this is a patient with a nice normal dens. We want to also assess, besides looking for the dens, the alignment between the lamina of C1 and the lamina of C2. And if we draw lines along the lamina, they should make a straight line, C1 and C2, so they should be in alignment. And then we can also assess the ventral aspect of the vertebral canal, and that should be in alignment as well. The patient on the right is a patient that actually has an aplastic dens, so no dens. Again, we have this lateral oblique view, and we have the wings of C1 separated. Here is the vertebral body of C2, and if we notice, the cranial part of the body is just round. There is no finger-like projection of the dens coming off from that, so this patient has aplasia of the dens. Now in this view, the patient still has normal alignment based on how we've positioned them. That does not mean there isn't instability there, but I can't actually identify instability right now. These are the same two patients, the normal patient and the affected patient on this slide. So we're looking now at the ventrodorsal view. On the ventrodorsal view, if we have our skull kind of straightened so that it's not flexed over and superimposed over the C1 and C2 area, on the ventrodorsal view, we can also assess for that dens without superimposition. So C1 with the wings, C2 kind of the whole vertebra, and then coming off the cranial part, we should see a well-formed odontoid process. Here's our affected patient. Again, we have C1 here with the wings. Here's C2 vertebra, and if you notice, the cranial part of the body is completely rounded and there is no odontoid process, so aplasia of the dens. And almost always, if they have aplasia or hypoplasia of the dens, they are going to have instability because the ligaments of the dens are no longer able to support the atlantoaxial joint when we don't have a dens. Here's the patient we've already looked at that's affected, and this was our neutral, slightly oblique lateral view where we could assess the wings of C1 and the cranial body without the dens. Again, I had seen that there was normal alignment on this view and a normal space. There should be a few millimeter space and no more than that. That space, because there's a ligament here as well, shouldn't really change much if we do some flexion or extension. This patient, the attending clinician, did a flex lateral view, and this demonstrates the problem and the instability nicely. However, I will say that you really should not do a flex lateral view unless you are very careful, and oftentimes if I am requested to do that, I want to do it under dynamic fluoroscopy, because you can see what happens when we flex this patient. C2 dorsally luxates or subluxates, so it's no longer lined up with the ventral canal of C1, and this space became very wide between the dorsal lamina of C1 and C2, and we no longer have a straight line between those lamina. So unfortunately, doing this sort of view can actually cause quite a bit of cord damage and compression. So I would really recommend that you don't do that unless you can do it while you're watching with fluoroscopy. So again, our lateral, our rotated or oblique to lateral, and our ventrodorsal view should be enough for us to be able to diagnose this condition. So here is an example from a different patient that I have both the lateral and the ventrodorsal view. The lateral view are a couple abnormalities that should be able to be identified. Now this is a straight lateral view, so notice the wings of C1 are superimposed where we could look for the dens, but I do see that the second cervical vertebra is dorsally subluxated relative to the first cervical vertebra. And if we drew a line of the lamina of C1 and compared it to a line of the lamina of C2, you can see that they make an angle. They are not a straight line, and there is increased space between C1 and C2. So there's quite a bit of instability on the lateral view. On the ventrodorsal view, when I look at C2 and the cranial part of the body, I can see that the dens is completely gone. So we have an aplastic dens as well. Here is another patient that we have a straight lateral and a ventrodorsal view. And this patient is not quite as malaligned as the other patient. However, if I look at the dorsal lamina of C1 compared to the dorsal lamina of C2, it doesn't make a straight line. So there is a little bit of mild malalignment. I can't really evaluate that odontoid process because the wings of C1 are superimposed. If you compare this back to a normal dog, there's also a little bit of an increased space between C1 and C2. And then on our ventrodorsal view, this patient has a very small dens, or a hypoplastic dens. So although there is a little one there, it is not a normal sized one. So this is another example of atlantoaxial subluxation. So we're going to finish out this presentation talking about cervical spondylomyelopathy. I've included this under the anomalies because anomalous development of vertebrae or anomalous stabilization is likely to play a role in the manifestation of clinical signs. Cervical spondylomyelopathy is also known as wobbler syndrome, and it is a complex condition of instability and compression affecting the spine. It is best to consider this a syndrome because it encompasses a constellation of pathologic changes. They're not all seen in every affected animal. And there are a few other synonyms you might hear: cervical spondylopathy, cervical vertebral malformation malarticulation, and cervical vertebral stenotic myelopathy. Just as an example, I have an MRI of the cervical spine in a Doberman where we have some changes on the MRI from this wobbler syndrome. There are discussions about really kind of considering two different forms of cervical spondylomyelopathy. The first one on the slide is called the disc-associated form. This form is most common in older large breed dogs, particularly the Doberman Pinscher, but other dogs such as Labradors and similar sized dogs. And in this form, the compression ultimately is usually due to disc protrusion as well as hypertrophy of the interarcuate ligament. And that's the ligament that is between the articular process joints. It's at the dorsal aspect of the vertebral canal. So typically the compression comes from dorsal and from ventral. There's also an osseous associated form, and this occurs in young giant breed dogs such as Mastiffs, Great Danes, and Bernese Mountain Dogs. In these patients, the compression is typically due to osseous proliferation of the articular processes, along with hypertrophy of their joint capsules and hypertrophy also of the interarcuate ligament. But the proliferation of the articular processes tends to be the more significant problem, and that actually causes compression from the lateral aspects. So a little bit different and a little bit different presentation. So older Dobermans, younger giant breed dogs. The most common vertebral column abnormalities can include the vertebral malformation, and the vertebral malformation is of the body, the pedicles, and or the articular processes. Stenosis of the vertebral foramen, so the intervertebral foramen between the two, can happen secondary to shortened pedicles and or the misshapen cervical vertebral bodies. That can also result in some instability or vertebral tipping, and I'll show you what that looks like on a radiograph. Also, as we said in the disc-associated form, you can have chronic intervertebral disc herniation, degeneration leading to herniation. And then there generally is ligamentous hypertrophy and vertebral remodeling in different places. We can also have proliferation of the joint capsule of the articular processes, so that's also a kind of soft tissue compression that can happen. And then finally, we can have osteoarthritis of the articular processes. We'll talk about that in a different presentation, but that can be part of this cervical spondylomyelopathy. The end result of these various abnormalities and the cause of the clinical signs is either static or dynamic spinal cord compression. So when you have osseous proliferation and or intervertebral disc herniation, that will lead to static compression. However, when you have ligamentous or capsular hypertrophy, that can lead to dynamic spinal cord compression. So depending on how the head is positioned, you can stretch out those ligaments and not see as much spinal cord compression. So some of these malformations and changes we can see on the radiograph. One thing to keep in mind, unfortunately, is that the radiographic findings are often mild, but if we see some of the findings that we'll talk about, it can suggest a diagnosis. And the findings can include misshapen vertebra, actual stenosis of the vertebral canal, so we can see that the vertebral canal is smaller at certain sites than at other sites. Coning, because oftentimes the canal is shaped more like a cone, with it being narrowed at the cranial part and wider at the caudal part. The vertebrae can be malaligned with respect to each other, and part of that is one of them can look like it is dorsally tipped, and then we can get enlargement of our articular processes and proliferation. So here, oftentimes these findings are easiest to see on a lateral view. So I have a lateral view of the mid to caudal cervical spine. This is a dog that has cervical spondylomyelopathy. Remember how to tell where we are. So if we look at this vertebra, we have those ventrally projected transverse processes expanded down here. So that is C6. So we're looking at C7, 6, 5, 4, and 3. So what I see at this patient, on this patient, for one thing, is a little bit of malalignment. So typically, I look at the spine in our 3-pass method, looking at the lamina, the canal, and then the bodies, and I can see that C5 here is a little bit dorsally tipped. So the cranial aspect of the body is more dorsal into the vertebral canal compared to the alignment of C4. So that is our dorsal tipping, or it's a little bit of malalignment or subluxation. Then when I think about the dorsal border of the vertebral canal and the ventral border of the vertebral canal, we should have a fairly parallel vertebral canal through our each of our vertebrae. When I look at C5, that canal is actually narrowed at the cranial aspect and more normal at the caudal aspect. This is that coning, because if you think about it, it's kind of making a cone. One thing to keep in mind is at C7, oftentimes, normally it looks a little bit coned. So typically I'm looking at changes not at C7 when I see that. Here's an example of a patient that has cervical spondylomyelopathy. I have lateral and ventrodorsal views, although I will say that the ventrodorsal view is not always as helpful. This patient doesn't have a lot of changes, but if I look at his cervical spine, this is C7, C6, I notice that C6 is a little bit narrowed at the vertebral canal cranially, so that's very mild coning. When I look at C7, it looks like it's a little bit of a step here, so this would be a little bit of that dorsal tipping at C7. And then when I look at the articular processes here between C5 and C6, they're enlarged and have some irregularity and sclerosis compared to the processes ahead and behind. So that is a little bit of proliferation of those articular processes. And then there's some bony proliferation ventrally. We're going to talk about spondylosis deformans later, but this is an attempt to try to stabilize this area. So these are mild changes, and I don't really see much on the ventrodorsal view, although sometimes you'll be able to identify those articular process enlargements. Here's an example of another dog that has some mild changes. When I look at the lateral view, especially when I'm coming down for alignment, I see that there's a little bit of a step of C6 relative to C5, so a little bit of step or dorsal tipping, C6 relative to C5. And when I look at the spacing between the vertebrae, the bodies, especially the intervertebral disc space between C5 and C6 and between C6 and C7, those spaces are narrowed. And I think that's a real finding. And remember, we talked about intervertebral disc herniation being part of this syndrome. We'll come back in a different presentation and talk more about intervertebral disc herniation and radiographic findings. Again, on the ventrodorsal view, probably the only thing I can see is that those intervertebral disc spaces are also narrowed. And then here's an example of, this slide, an example of one of the presentations of the osseous form in a young Great Dane, although again, we can sometimes see similar findings as on the disc-associated form. In this patient, when I look at the lateral view of the cervical spine, the one really more evident abnormality I can identify is looking at the vertebral canal. So let's look at C4 here and compare this vertebral canal that has a parallel dorsal and ventral aspect to it. When we look at C5, this vertebra is really malformed. So cranially, the canal is a little bit more narrowed, and then it has kind of this irregular widening out at the caudal aspect. The other thing that is not as evident, but I think is real, is some proliferative changes here at the spinous processes, or the articular processes, probably even a little bit back here. So there are some abnormally shaped articular processes. Certainly for cervical spondylomyelopathy, we do need to get additional imaging. This is especially important because a lot of times the abnormality may not be where the radiographic abnormality is, our compressive abnormality. So this is just an example of that same patient from the previous slide, the young Great Dane, where we have obtained MRI images. And what we can see at the site of compression is that the cord is narrowed. The cord has a different kind of appearance as well. It's brighter. It has more intensity in it. And then because these patients, if you recall, I said the osseous form oftentimes have compression from the lateral aspects, looking at our transverse images is going to be really important. This is just the normal site, unaffected site in this patient where the cord is this medium gray. We've got our subarachnoid space and fat around it, and there's no compression on it. When we look at the affected site, the cord is compressed. We don't have as much white around it, which would be our fat and our subarachnoid space, and it's because of these osseous changes out here. He has both lateral compression as well as some dorsal compression, and that's because those ligaments that hypertrophy are dorsal. Again, remember to consult your textbook chapter and readings so that you can have any additional explanation, and also to identify and view additional examples. And I've listed the 2 chapters and the pages that are over the topic we just discussed.